the patient stented. But you can sometimes, especially in women, they go up. The only thing I'd say is, if you are using an access sheath and the patient's pre-stented and the operation is easy, you don't necessarily need to leave a stent in afterwards. But if they haven't been pre-stented and use an access sheath, then I would say you should always put a stent in afterwards, because they do cause and again, it's another reason for not operating too long, because the worry obviously is the pressure necrosis on the ureteric wall. So again, up to 90 minutes, I'm not worried. Longer than that, that's when you get into stricture territory. I don't know what you guys feel, but
I never operate more than 90 ever.
yeah. I think it's a hard ceiling for me, 90 minutes. And you know, I'm as you probably can tell, I have got clinical OCD, which causes me a lot of problems actually. But sometimes it's helpful, and one of them is that whenever I start the operation, and I don't have to ask them anymore, the theatre sister will start the clock, and then I'll get a prompt at 45 minutes, an hour, and you know, by that point I'm thinking about exit. Good. Again, obviously we can pick up some of these things this afternoon when we're. The other thing, by the way, you know, I wave my hands. You can always tell who's an endourologist, because when we talk, it's always accompanied by, as I put a wire in, twist the scope. You know, the hands are always moving, and it's a good way of thinking about what you're doing in the theatre. And sometimes I get the registrar to shut their eyes and just picture that they're holding a scope, and it's helpful. Okay, good.